I'm on the total opposite end of the spectrum. Even though I've been a clinician researcher for 25 years, I'm talking about a small individual program that's been continuously operating for 7 years without any federal or any other type of external support or being connected to a large agency of any type. And it's sort of my passion as a clinician researcher to see something translated into action, to see how you can make it work with no funding, and actually try it in the real world. So this is a small program, but hopefully we can all learn from what I've been trying to make happen for a long time. And even though it's a small program, it's based on science. It's empirically driven. And the research has been out there for a long time. And God bless Lynn Bittner, who we lost a couple of months ago, for her dedication in informing us about what works in the real world for her 20 years of her career. Because a lot of my work is based on her studies and my own studies and studies that have come out of Washington and a lot of other places. So it's an empirically driven model that's been translated into this small community-based program. And our intent is really to fill the gap between diagnosis and when people are ready for adult daycare. And that can be years, and we know that there's not programs available to fill this gap. Oh, before I die, I would love to see us hand the script for Aricept or whatever is the newest drug and hand the script for non-drug treatments at the same time, because we know they work. I mean, the data's been out there since the 1980s on animal studies and since the 1990s on human studies about the effects of enriched environments, et cetera. Unfortunately, these studies don't fare well in systematic reviews. And I'm going to digress just a second and say we understand that as a scientific community. And my good friend and colleague, Jessica Cohen-Mansfield, I asked her for her manuscript before I came today because she has a manuscript under review with a group of colleagues that we share that talks about why these small studies don't fare well in systematic reviews, and I can't wait for that to get in the literature. I'm just completing a manuscript on the describing the effects of non-drug therapies on the brain. We know how these therapies work on the brain. We understand the physical mechanisms, but those publications are scattered throughout the literature, so I'm just completing a manuscript that describes 11 different non-drug therapies and the effects they have on the brain. So the purpose of my program is not just to make people feel better. It does, but I also think we're affecting what happens in the brain. I think we have the potential to do that, and we know that. So it's based on the most well-supported non-drug treatments. By the way, I understand that this is problematic, non-drug, non-pharmacological, and I know there's been people also trying to address that. What do you call these treatments that's not so wordy and that makes sense to people? And so I apologize for the terminology, but it's a common problem. So my Minds in Motion program meets weekly, and it's been continuously operating. It's not time limited. We're in our 7th year. We're ending our 7th year. It includes the most well-supported non-drug treatments. We do physical exercises, aerobic exercises, and those that require a memory for muscle movement are the most well-supported. So we purposely do Tai Chi and Qigong exercises. That's all based on what we understand about the effects of exercise. We do mental exercises or cognitive treatments every day that we meet. And then we do some kind of creative activity, which we also know has direct effects on the brain. And the other purpose of the program is normalization. Having people come to a program with other people with similar issues, all MCI or early stage, and being able to feel accepted, to feel really well supported. So that normalization component, I think, is highly important. What are our outcomes? This isn't a research study. I have refused, and I have somebody who came to me a few weeks ago who's here in the audience and said, I'm interested in doing research. And I said, great, we can start another program, but this will not become a research study. Then it becomes non-normal. If you consent people, if you do trained interventionists, then it becomes not a community-based normalization program. But we do measure outcomes. We measure mental status, the MMSE, the EXA 25, depression, and functional ability annually. We've had good outcomes, and I could give you numbers, but the stories are what counts. Jim's MMSE and his mental status scores improved after the first year. They haven't gone down. He's been in our program 7 years. continuously. Irene had a hip fracture at 91. She was back at our program in 3 months and went back to live at home. These are outcomes that you don't often see. Those are the outcomes I care about. Having said this, it's one of 2 such programs in the state of Illinois. And the second one is connected to a large older adult center on the North Shore of Chicago. We're sitting in a church in central Illinois. So having said that we can show we have positive outcomes. I charge $18 a day or $180 a semester. It's all self-pay. There's no insurance. If people can't afford to pay, they're given a scholarship. I beg and borrow for that money to cover scholarships or cover it myself. It's a kind of community-driven program that I think fills a needed gap in the community that can operate without a lot of other support, but it takes a lot of the kind of legwork that's necessary to make it happen. So why are there only 2 programs like this in the state of Illinois? First of all, we don't have the protocol. We don't have a well-developed treatment protocol that we know we can hand to people. So it takes somebody who has an understanding of the science and the clinical implications to develop these and make them work. There just aren't a lot of us out there who are willing to, and able to do this kind of work. There's a lack of incentives. Do I get professional kudos for this work? No, to be quite honest. The University of Illinois is a great place, but it wasn't something that went up on my annual report as being a plottable part of my work. So there's really not a lot of incentives at this time, I think, to really disseminate and implement these programs on a large-scale basis. Thank you.
So now we're going to have some time for questions that I'm going to ask the panelists to respond to. First, I'm very impressed by the quality of your interventions and their contributions to the field, as I'm sure many of you are. Can you please tell us a little bit about some of the hurdles that you know about related to translating these interventions that different sites have experienced?
Well, when I think about hurdles, I think there's hurdles with a small h and hurdles with a capital H. And the small h hurdles are the things that the sites who are doing the translation have to grapple with from the get-go. So it's things, for example, who is going to be your target population? We talked earlier about in a randomized trial with RDAD, for example, we had people with very carefully diagnosed Alzheimer's disease. As we take it out into community, we need to open that up to general dementia more broadly. But we also need to think about, are there persons with certain kinds of dementia that really are not a good candidate for a program like ours? And if so, what would those reasons be that they wouldn't be good candidates? Another example would be who's delivering the intervention. In the original randomized trial, we had physical therapists and social workers that were delivering the intervention. And as we take it out into the community, we're having case managers or we're having staff in the Alzheimer's Association. So I think of these as being hurdles, but they're hurdles that can be overcome with conversation and thought about what's appropriate for each setting. The larger hurdles, I think, do have to do with long-term sustainability of a program. You can train individuals to do a program, but over time, people move on. You need to have something in place to ensure that there's an influx of new qualified individuals, that those qualified individuals somehow are monitored for some period of time or episodically to make sure that they're still doing what they were trained to do, that there's some sort of treatment quality adherence that's maintained over time. I think these are the kinds of, you need to think about what's going to be the level of involvement of the persons who developed the intervention initially. You know, do the developers stay involved? Do they just step out after a point? How do individuals become certified to be qualified to deliver these interventions? These kinds of things, I think, are the capital H hurdles that we don't really have answers for yet.
Okay. I think the biggest hurdle that we've struggled with is probably in terms of recruitment. And we're trying to replicate this in very small rural areas. And to be quite frank, doctors aren't diagnosing people early. And so you can start a program, but there's nobody to be in the program unless you have a really good physician in the community who's diagnosing people very early in the disease and then referring them. And so I think, part of the three-legged stool and the reason for it is that we absolutely have to change the way people are diagnosed and managed in healthcare in order for people to receive early treatment of any kind. So I think that's something that, as we're developing these non-drug treatments, we're also sending out an away team to work with physicians on how they can integrate early identification into their practice. So that's what I'll say for now.
I think the whole issue of appropriate referrals is a hurdle we face every day. I think the other thing and it kind of goes along with what I've already said, there's not a lot of public knowledge about treatments that are positive other than drugs. So when you start talking about coming and doing Tai Chi, people, it's sort of like, well, that sounds nice, but they don't understand that it can actually affect their cognition or their cognitive functioning or their brain. So we haven't really made that information very available. I just got a referral from a physician in a community of 5,000, and when the woman called me, she said, I went to the doctor, and he said they could actually treat this, and she was so shocked that there was actually a treatment. And that's just one example, but it's really sort of real life. People don't understand that there are treatments, and I think that's a whole public education issue.
Thank you. You had each mentioned working with healthcare providers. What have you found have been some effective strategies in partnering with them, either through your program or perhaps through other programs that you've worked with, working with people with Alzheimer's and their caregivers?
Do you want to start?
I do a lot of presentations, and I'm trying to retire, but I find it really helps to talk to people about it, and I'll do, we have a primary, actually I convinced my clinical site, SIU, which is a National Disease Center in Springfield, Illinois, to do a primary prevention conference. They now offer annually a primary prevention conference. Actually, Susan came and spoke for us a couple years ago. It's attended by physicians. And they bring national speakers in to talk about primary prevention. So I've tried to really do a lot at that level, working with centers to help them understand the whole issue of prevention and how important it is to get that information out to those who are practicing in the field. I don't think it's that practitioners don't want to do this right. I don't think they have the necessary tools to do this right, the necessary understandings about the disease and where the research is. And do I expect the average family practice doc to look at the research around dementia? No. I mean, they don't have the time for that. So I think we have to be responsible for making this information accessible. And that's one of the strategies I've used, is to really work with disease centers. And I think our primary prevention conference is just one mechanism, besides speaking at a lot of CME types of programs to talk about the science behind non-drug treatments.
Thank you. We actually are trying a number of different things to try to tackle this particularly large beast, if you will. We have a group called Prepare Minnesota for Alzheimer's by 2020, which is, I suppose, the Minnesota version of NAPA. And there's a leadership group that works just on this problem. And we have, as part of that group, created tools that one of the things that we felt were absent was that physicians were saying, great, that sounds great. How do I integrate that into my practice? And so we created an algorithm for, I would say, screening, but publicly I would say assessment of people in a primary care clinic, followed by an algorithm for diagnosis, followed by an algorithm for post-diagnostic management of the disease. This is all based on work that's been done in many different settings, probably by many of the people in this room, and then translated into easy-to-use tools, which if anybody has one, could hold it up, but I brought them if anybody's interested. And we hired somebody who used to be a pharmaceutical rep and indoctrinated that person. And then that person, we've developed target lists of physicians in our community. And we literally go physician to physician, spreading the good news about how dementia treatment can be different in practice. And once we get a bite, we promote a program called Direct Connect, which is a way for physicians to get permission from families to release medical information. That information is faxed to us, and then we contact the family directly within 2 weeks of their diagnosis, and then give feedback to the physician. And we find that encourages earlier diagnosis over time, because we continue to work with the physician about that, and they see that there's something they can do. And then once we get the families, if they're early, we also have the mentors then calling people with early dementia and bringing them into this larger network.
The Hill just broke that the Supreme Court upholds the healthcare law and the individual mandate.